Joint preservation and restoration, what is that? It's just, we all have joints and we all want to preserve the joints we have for as long as we can, right? And so this talk is kind of a broad overview. There's a lot of technical slides in here, so I won't get lost in all the technical stuff. But it's just kind of a broad overview of things we can do to help preserve the joints that you have. Some things that have been around a while, some new things, and some up and coming things. So stop me at any time and ask questions. This is very informal, so if you got a question, ask. Any question is a good question. Okay, so this whole topic of joint preservation and restoration, you got to think about, what are our goals treating people? Well, we want to decrease pain. That's the reason we do anything in orthopedics, right? Is to try to treat pain. And we want to maintain the function of your joint, hopefully with as little pain as possible. So, and a lot of this is focused on the cartilage, right? The inside of your joint. These are working. So all the ends of the bone and in your joints are lined with articular cartilage, which is the white stuff, right? That's what all this is about, preserving that smooth white cartilage. When that starts breaking down and getting cracks in it, that's what we term arthritis or cartilage damage. And then that's when the pain starts, and that's this whole cascade of arthritis is when that smooth cartilage starts breaking down, which looks like this. See that? Looks like crab meat, and that's when the cartilage starts breaking down. That is arthritis. That's what it looks like. From anywhere from a crack till the cartilage falls off and your bone is exposed, right? So once cartilage breaks down, that's it. It doesn't heal itself. Once it's gone forever. Okay, that native smooth cartilage, that's all you've got. And when it starts breaking down, it doesn't come back.
Your body doesn't produce any more cartilage?
No, it produces scar cartilage, and I'll show you that later. But once your native cartilage is gone, it's gone. And we can't get it back. But there are things we can do to help stimulate scar cartilage and do other things. So William Hunter, back in 1743, said, ulcerated cartilage is universally allowed to be a very troublesome disease that when destroyed is not recovered. So we don't get it back. And back in the 1700s, they knew this as well, and it hasn't changed. So this is just a picture of what cartilage looks like under a microscope. Here you can see the bone, and there's different layers of cartilage within that white cartilage, right? So there's all these different calcified layers and a radial layer and a transitional layer. There's all these different layers, but that cartilage has a certain thickness, a few millimeters, that contain these layers before you hit bone. Once all these are gone and you hit bone, that's when the pain starts. Okay? So there's a guy in San Francisco named Scott Dye, and he talks about this envelope of function of your knee. It's really good. He's an orthopedic surgeon. He's written a lot of great articles on this envelope of function. He's also, believe it or not, he had somebody, we do arthroscopy where we put cameras in joints. Well, he wrote a paper. He had somebody scope his knee while he was awake, right, with just local anesthetic on the skin. And they went around the knee and started poking and prodding, and he wrote a paper on what hurts in the knee. It's a really incredible paper. So he just had somebody scope his knee while he was awake. They poked on the cartilage, grabbed stuff. Yeah, that hurts. No, that doesn't hurt. And so he wrote this great article about what actually hurts in the knee. So he talks about this envelope of function. This is critically important. All my patients, really over 50 that I scope their knee, we talk about this envelope of function. And so, it's the envelope that your knee functions in before you start to develop pain, right? It deals with the bone, the soft tissue, and overload of the cartilage. And so you have to respect this envelope of function. And a lot of orthopedic surgeons don't understand this, but this is probably the most critical thing in understanding why people get pain in their knee. It's not just the cartilage. It's the bone, it's the soft tissue around the knee, it's the cartilage, it's a lot of different factors that contribute to pain. So things we have to consider, right? Inside of your joint, you have the meniscus, the cushion cartilage. You have bone, you have cartilage, you have ligaments that hold your knee together. You have synovium, which is the lining of your joint that helps create fluid to lubricate your knee, right? You have to think of movement. You have to think of people's alignment, right? I've seen people walking around, right? You've seen people who are real bow-legged. I've seen a couple here already walking around. Their knees are, looks like, very bow-legged. Or some people, their knees are very knock-kneed. All that goes into consideration when treating knee problems. So the other considerations are the patients and the patient expectations, right? The overall patient health, what the goals are, how committed they are to these treatments that we do, and the biggest thing, what are their expectations in this, right? Like you said, the cartilage is gone, it's gone forever. We can't cure that, but we can hopefully decrease the pain and make it tolerable, and that's the goal of a lot of these treatments, okay? And then the surgeon that you go to, it's, what skills do they have? What are the tools that we have in our box to treat this? How much experience have they had? How well versed are they in all these specific treatments? And then developing a program, right? Whether it be physical therapy, supplements, fitness, equipment, there's all kinds of, tools that we can use. Open the paper, turn on the TV, right? There's tons of stuff out there. Every time you open a book, magazine, commercial about we can cure arthritis, the latest treatments, right? There's a lot of good things out there. There's a lot of bad things out there. So this is complex, right? There's a lot of things out there, and to help try to weed through what works and what doesn't. That's the kind of the goal of this talk, to help educate you a little bit, all right? Expectations are realistic. I say this, you can't make chicken salad out of, right? We've all heard that term. It's true. You got, we can do good, but we can't work miracles sometimes, all right? So there's these different cases. You got to think, when patients come to me, you got to think of their age, right? There's 50-year-olds, a non-smoker male who has joint pain on the inside of his knee. A lot of people have had their knee scoped and had part of that meniscus taken out, the cushion cartilage, right? His goals are tennis, hiking, playing ball with the kids. You got to think of what are the goals? What do people want? Do they want to run marathons, or do they want to play in the yard with their kids, right? You have to look, things we consider, I go back, these x-rays just show alignment, right? And this is an MRI picture. So usually we'll get MRIs. We'll get plain x-rays if people have very bad alignment and they're young, because we can correct their alignment. MRIs help us look at soft tissue injuries, cartilage injuries, meniscus tears, things like that. Here's another, this is a 58-year-old, you got to think, where do they have pain? Is it on the inside of the knee? Is it on the outside of the knee? Is it in the back of the knee? Again, what are the goals? These x-rays, much different than the other ones, you can see they have no joint space here. Look at that. All that's bone touching bone. That's things we look for on x-ray. You can see the alignment there. Definitely more knock-kneed than bow-legged, right? So if you draw a line from the center of the hip to the center of the ankle, that tells you where you bear weight when you walk. So when I see x-rays like these, that line's probably going right through here, which tells you, people that are knock-kneed have more problems on the outside of the joint. People that are more bow-legged have problems on the inside of the joint. And then there's all kinds of things we can do. Anti-inflammatory medicines. We'll go through the list here in a minute. So what are the current tools we have, and what are the future tools coming down the pipeline, right? So this chondroprotection. That chondro is a term that describes cartilage, right? Protection, we're trying to protect cartilage, right? How do we protect the cartilage? Well, we have ways we can do it non-operatively, medications, injections, things like that. And what surgical options do we have? Cartilage restoration, right? Again, your cartilage you have is gone forever, but you can form scar cartilage, which is that fibrocartilage. And so now just talking about cartilage protection, what we're trying to do is delay, minimize the cartilage breakdown, and decrease your pain, all right? Cartilage that has an injury, I see people all the time. Guy's 18 years old, he injured his knee in high school. My knee is big and swollen, I kind of ignored it. At that time, he probably tore his ACL. Now he's 42, he comes to see me, and he's got horrible arthritis, and that original injury does something to the cartilage. In some people, it sets off this cascade that they just end up getting an arthritic knee. Some people don't, but a lot of the times, we try to slow that process down. So non-operative tools, non-surgical tools, what things do we use, right? people that come in that we say, hey, you've got some arthritis in your knee, early arthritis, what can we do for you? There are braces out there. These are called unloader braces. So people that are very bow-legged, you have to think, remember I told you, you draw a line from the hip to the ankle, that tells you where you're bearing weight. They make braces that when you take a step, if you're bow-legged, it pushes your knee in that way to try to correct this where you bear weight. The center, it takes the pressure off the inside of your knee. And so when you take a step, it pushes here to unload your joint. And so they make those for people with arthritis on the inside, the outside of their knee. So that's an option. That works well for people who have usually just arthritis on the inside of the knee or the outside of the knee. It doesn't work for both. So just that alignment problem is definitely a risk factor for developing arthritis if you're very knock-kneed or bow-legged. Strengthening exercises, so this is where therapy comes in, right? Therapy works. We know it works. It's been proven to work. There's different studies that show that strengthening exercises, even with an arthritic joint, are beneficial. Exercise for an arthritic joint is extremely important. Motion is healthy for an arthritic joint. What gets people with arthritic joints is pounding, right? Walking. When you walk, you put 3 times your body weight through your knee. When you run, you put 6 to 9 times your body weight through your joint, right? Bicycle, you put less than 1 times your body weight through your joint. So the motion is healthy. What gets you is the pounding. That's what people get in trouble. Elliptical is good too, because you're getting the motion without the pounding. It's very good for arthritic joints. Usually it's less than 1 times your body weight, about one to a little under that. So it's very healthy. People think, oh, I've got arthritis, I can't exercise. You can. I tell people, you can get in a pool, get on a bike, get an elliptical trainer. The motion is healthy. It helps lubricate your joint. Oral supplements, right? There's a jillion of these on the market. Glucosamine chondroitin, that's the most common, right? People hear about that all the time. You see it everywhere. Joint juice. There's some studies to show that it can be helpful with, moderate to severe osteoarthritis. There's several studies that look at it. They're not great studies. It doesn't slow the progression, but sometimes it can help. Glucosamine and chondroitin sulfate are the building blocks of your articular cartilage. That's what they're made of. So it helps support the cartilage you have. And some studies have shown that it can decrease pain. I tell patients, try it 2 to 4 weeks. If you notice a difference, you can keep taking it. If you take it and stop it and start hurting, you know it's working, so it may be worth doing. And there's other stuff on the market, DMSO and seaweed, and that list could be 2 pages long of stuff that claims to, you got to remember the supplement industry is not regulated by the FDA. So technically you could put dirt in a capsule and say it cures whatever, right? It's not, a lot of these some are studied, but it's not a regulated industry. So there's a lot of stuff out there. You got to be careful. Injections, right? So we do, usually the first line of defense, I see somebody with arthritis in their knee, I tell them you can do a steroid shot, you can do a gel shot, you can do plasma injections. Steroid shot's kind of the first line of defense. It works great. It's a potent anti-inflammatory. It takes it and injects it right into your joint. Usually works. We can do it safely every 3 months or so. Some people get more, some people get less. The other type of injection, you've heard of these gel injections, and I've heard them called everything. Rooster cone, what else? There's all kinds of terms for it. So these are lubricant gel injections. It's like putting WD-40 on a squeaky joint, right? It decreases the friction in your knee and acts as a shock absorber. So that's this hyaluronic acid and viscosupplementation, right? Those have been shown to decrease pain and increase function, yes. One study claims that it's better and longer than cortisone. I tell people it's very patient specific. I have people that do the gel shot that love it. Some people do it that doesn't work at all. Same with steroid. So you don't know until you try it. And so I'll use these gel injections a lot. We use them here all the time. A lot of times if I do arthroscopy on somebody's knee, if they have a meniscus tear and they have some arthritis and we clean it up, 6 or 8 weeks after surgery, we'll do these gel injections. So it's kind of a package treatment that we get. This is all to the gel shots. Does it preserve the cartilage? Maybe, we don't know, right? It helps as a shock absorber and lubricates the inside of your knee. I tell people it's like putting mineral oil on your hands. It just decreases friction. Cytokines are things that are, I'll get into platelet-rich plasma in a minute, but things that are in our own body and in our own blood plasma that act as anti-inflammatory, our own natural built-in anti-inflammatory things that help sometimes we think, preserve and help nourish cartilage somehow, so this may help. So, all right. Does it repair and restore? Maybe. We don't know, right? This is, just that little bit of, that doesn't look bad, right, compared to the other knee, but those cracks in the cartilage, that's where it starts, is a crack, and then it progresses over time, right? One study showed that it had less cartilage cell death with these hyaluronic acid injections, but there's these medications like Remicade, right, which is a medication they use for rheumatoid arthritis. This TNF alpha is a tumor necrosis factor. It's just a fancy term for a thing that causes inflammation, right? And so they think this may inhibit inflammation by inhibiting this little bad guy. PRP, so this is another, I'm sure a lot of you have heard of platelet-rich plasma. This goes into the kind of the stem cell, this other stuff, right? And so there's steroid shots, the gel shots, and I tell people the third option is the plasma injections. I've got a lot of experience with this. I've done this on myself, not for arthritis, but I was kind of patient number one about 6 years ago. Since then, I've probably done several thousand of these injections on people for soft tissue injuries and a lot of arthritis starting a couple, 2 or 3 years ago. My own personal experience is this works really good. Between the three, if insurance paid for this, I would do this. What it is we take your blood, spin it down, and separate the plasma out. The plasma has all kinds of goodies in it, right? It's the platelet rich. I don't know if it has much to do with the platelets, and there's where the argument is, right? This works. Can we tell you exactly how it works? No. We think there's a lot of goodies, the cytokines and healing factors and growth factors and all this stuff that's in your plasma that takes advantage of your body's own anti-inflammatory properties to heal itself. So my own personal experience between the three of these, and there's good science and studies to back this up now, whereas some of the other stuff, it's kind of, the studies out there are wishy-washy. There's some really good level 1, which is the best science that we can come up with on plasma that says it works better than the gel injections, better than steroid, better than placebo, and my experience has been just that. I've had a lot of skeptics and a lot of people with horrific arthritis that I've done this on that's worked from about 6 months. The studies say 6 months. I've got some that are a year to 2 years. It's crazy. So yeah, my conversion rate on the patients I've done it into a total knee, I bet I can count on my hand. It's crazy. I mean, they work for me. It's hurting my joint business, which makes me wonder why am I doing it. But no. $500 we charge for a series of 3. And I tell people I'll give your money back if it doesn't work. I'm not trying to, and I've only had to give money back one time. It was a guy who was 92, and he came in, remember that guy? I gave him one shot, and then he was supposed to get a total knee anyway. So he didn't give it long enough. It's 1 a week for 3 weeks, and that's just how the studies were done. There's no real data and science behind that. Oh, I've done it in the shoulder, yes. I've done shoulders, toes, fingers, knees, thumbs. Here we go. The stem cells. Stem cells are just all your cells. It's the base cell that all cells are made of, right? And so they think, well, if we go get stem cells out of your bone marrow, that's the key trick to this, right? We got to get the stem cells and we'll inject those in there. Well, or we inject them suspended in that hyaluronic acid, which are the building blocks, right? And so all these studies are going on with stem cells and plasma, and my argument on this is the stem cell stuff, it's the jury's still out. There's not a lot of good studies out there saying, plasma works better than this stuff gets expensive. You want to talk about $500? Okay, go start calling around for stem cell injections and things like that. We're talking multiples of 5,000, 6,000. I mean, there's some, you can pay a lot for this. And I tell people I've done mine the same way for the last 7 years. And until people start telling me this doesn't work, why am I going to go do something that's 10x the cost if I'm getting good results using, So we like science and data to back up what we're doing. That's the key. And so I'm not knocking stem cells. It may be there. We're just not there yet. I mean, weekly we get people coming in. What about stem cells? I need stem cells. You doing stem cells? I'm going to Germany to get. I'm like, you can go. It's expensive to fly over there and pay them all that money, but there's, it's, yeah, a lot of this is fed by marketing and ESPN and all this other stuff we're out there, but the science behind it, this is awesome area. This is growing, this is huge. It may be stem cells, it may be this, but right now we're trying to figure all this out. So just keep that in mind. So that's not operative stuff. Operative, what can we do? Well, if it's an alignment problem and somebody's young and they have really bad alignment and haven't developed a lot of arthritis, then we can correct their alignment, right? That's this picture here. We can go in and basically break your bone, put a plate on it, and correct your alignment. That's for the 40, 50-year-old, no arthritis, bad alignment issue, trying to preserve the joint, all right? We do, that's this HTO, it's called high tibial osteotomy, where you just go in and cut the bone and realign it, put a plate and screws on there. That's a big deal. So other things we can do. So the meniscus is the cushion cartilage, right? Shaped like a C, there's one on each side of your knee. Once you lose this, it's gone as well. But we can do meniscal transplants where we take cadaver meniscus and transplant it into a knee. I've done this before. It's usually the last one I did was a girl, she was 24. She'd had a previous knee injury where they'd taken out her whole meniscus. And that's what they used to do 30 years ago or longer. You get a meniscus tear, they'd whack the whole thing out. Then some of those people were coming back several years later needing developing bad arthritis. Some didn't. So that meniscus serves a purpose. And so in a young patient who has no meniscus, who has no arthritis, an option is to transplant a meniscus, right? You can go in and get a cadaver meniscus and put it in there. Done that before, and it's neat. But and then this future, they're making these meniscus, instead of getting them from a cadaver, making them out of collagen, right? So that's another potential thing that's coming down the pipeline. They've been developed. It's just they're not in the States. But again, those transplants are for people without arthritic knees, right? That's once you start developing arthritis, then it changes to this topic, the restoration, right? So once you've got arthritis and got cartilage damage, then we got to figure out, okay, how do we protect what you've got and slow the process down, right? So there's 200 and something causes of arthritis. Trauma, genetics, right? Just good old-fashioned genetics, right? Mom had it, dad had it, relatives had it. You can get these osteochondral, these fractures, people just knock off a piece, right? Big piece of bone. Or here where it's just all arthritic, right? So things that we can do, right? I don't know if you've heard microfracture, right? Is where works well this is a surgical technique where people who have isolated small, they say less than 2 to 2.5 centimeters, right? So about dime to quarter size lesions where you knock off a piece of cartilage. Usually this is a younger person, athlete. It can be whoever. Some people have a trauma where they'll shear off a piece of cartilage. If it's small, we can go in there and drill holes in the bone. See this? You drill these holes. And we look for that blood. That blood will then form a scar cartilage cap called fibrocartilage. So you don't grow new cartilage, but you can fill in the pothole with the scar and it works. This has been around for a long time. The guy where I did my fellowship invented this, Dr. Stedman, and it's been tried, true, proven over and over again, and it works. It's the first line of defense. It's easy. It's inexpensive. It's an outpatient surgical procedure. But that's your body's own ability to heal itself, right? We're pretty good at healing ourselves if we let it, for this kind of stuff. But that forms fibrocartilage, which is scar cartilage, and that's just showing the picture here. But it'll fill in the gap. See that afterwards, before, after? You can see the potholes filled in. So what hurts is that exposed bone. Remember the guy who did the study where he went around his knee? They poked on his cartilage, didn't hurt, right? Just poking on your cartilage doesn't hurt. What hurts is when there's exposed bone. That's where the nerve fibers are, and so that's what causes the pain. So again, microfracture has been around a long time and it works. And that's my first line of defense for everybody on these things. We try that. If that doesn't work, then it gets bigger, more complicated, more expensive.
Is that covered by insurance?
Yeah. And it's as simple as just poking a few holes in the bone, and that's what we do, right? It's the original cell-based therapy and has been studied and restudied and studied again. Right? And so that's what it looks like after we drill the holes. And then you can't walk on the joint, right? It forms this superclot. These are stem cells, right? We're stimulating your bone marrow, and all this good stuff flows out of there in the blood, and all these cells, stem cells, and it forms this superclot, and then over about 6 weeks' time, it forms this fibrocartilage cap. So anyway, it's been studied and works well. All right. Future, again, these hyaluronic acid injections, do we inject people in the operating room with hyaluronic acid? Do we put stem cells in there? I think you're getting stem cells from the marrow. So this is all kind of stuff that's being studied now. What do we do? Do we do microfracture? Do we add some stuff to it? And there's all these BMPs, are called bone morphogenic proteins, or these different scaffolds that you can put in there laced with cartilage cells. There's all kinds of stuff we're looking at now. All these little growth factors, those little cytokines and things, is there stuff we can do with that? So that's where things are headed. And they have these gel matrices and all this stuff where you do inject stuff into this collagen and put it in there. This is all stuff that's being looked at right now. So this is a big area. And then this autologous chondrocytes. So those is another type of procedure where we can take some of your own cartilage cells. This requires, it's for bigger lesions. So see this, the microfracture works for smaller. Once you get above 2.5 square centimeters, that's a little big for microfracture. Studies say it works best if it's for small contained lesions. When it starts getting bigger, then we got to think of what are other options. It's called ACL, autologous chondrocyte implantation. It's a procedure that has good results, but it's very expensive. It requires 2 operations. You have to go in one time, harvest your cartilage cells, and we send those off. They grow more cartilage cells, and you have to have another operation where you go implant the cartilage cells with this. You see this little cap right there. We take a little, it's called periosteum, and sew it around there and kind of let your body heal it, right? So that's another. It's an open procedure. It takes 2 operations. And guess what? When you're all said and done, all the studies have shown it's similar to microfracture, right? So that's a lot to undergo, and it's very expensive to get the same results as drilling some holes in the bone, right? So that's why we keep going back to microfracture. But this is another option. There's, future cell-based strategies. So I'll talk about these little scaffolds, these collagen scaffolds, stem cells, and all the stuff that we're looking at now to help try to fill in the pothole. There's other stuff I've done also. So they take minced articular cartilage. So these are things we're actually doing now. The second one's pretty interesting. It's called de novo. They take neonatal cartilage cells. I've done this several times in the ankle, and that's where we tend to do this. But you're implanting cartilage cells from neonates that they harvest, and you put it in this in the defect, and you put this glue on it, and it seals it up. And so that was, when it first came out, people were doing it, but I think we keep going back to microfracture, right? All the results. Again, and now they're doing these tissue engineered stem cells where they take fat and develop chondrocytes out of this. And so there's all in this gene therapies, and there's all this stuff going on. This is a hot area right now. When there are other options we have where we can take, if you've got a big defect that's deep, right? We can go steal bone plugs from other areas of your body, particularly your knee, and we can take plugs of bone with cartilage on it, and we can transplant those other areas. Like I've taken them out of the knee before and put them in the ankle. Or you take them out of the knee and put it in the knee, just an area where you don't bear weight in the knee. So you can take plugs from yourself or from cadavers. They have these little round lesions right here, and you go in, circle it out, and then put a plug in right there. See, the plug has bone and cartilage. And that's what it looks like afterwards. And so that bone then heals to bone. And so those, again, are for isolated lesions, not for arthritis that's all over your knee. That's what the plug looks like right there. And we can do different diameters. We do this a lot where we take a plug from the knee and put it in the ankle. So very common. You know, the plug, it grows into the bone. So the bone behind it heals in, and then you've got that cap above it. And so that's just showing here. You can see it's got two plugs there. And so, you know, it works for smaller lesions too. But usually we'll do this, say if I do microfracture on somebody, and for some reason that doesn't work, or they have a problem later, and then you can re-microfracture. There have been studies on that, but you can also, this is kind of our next step technique is, okay, we're going to go take bone plugs. Anyway, this whole thing is just developing this program about joint restoration, right? We're trying to get all these factors to come together, you know, based on the patient, what they need and their specific, you know, what are their goals, what do their x-rays look like? Everybody's kind of different. Develop this plan of, you know, nutrition, supplementation, bracing, shots, surgery, all this goes into effect, right? But we've got to communicate well with each other, right? It's all sitting about expectations. So much of what we do is patient expectations, right? What do you expect? What do we expect? And what can we do for you? That's the biggest thing. So Hunter would be amazed at our progress, right? Since 1743. Cartilage can be preserved, protected, and restored, but once it's gone forever. So we want to get that zone of homeostasis, right? We want things to be happy. Know and grow your own toolbox. I know it's confusing. There's a lot of ways to go.